assured me that that the students, just like I sent out in that email, that they would be allowed to take it anytime it's scheduled. Now, if you're going on a day and they're not doing flu shots, then yes, you cannot get it that day. But if you are going on any day that is scheduled for flu shots, you should be able to get on that day. So let me call her again to make sure that she informs the front desk. Okay, I don't want anyone getting turned away.
Thank you.
Mm-hmm. Oh, but again, I'm asking you to only go on days that they are scheduled flu shot offerings. Okay. On the times that they allow you to. Good morning, everyone. How was your weekend?
Good morning.
Ready for another wonderful week of learning? Just so much to learn. I am super excited. We're going to finish up pathology today. We'll be ready for your exam on Wednesday. I do want to talk about that. Not too long, because I want to finish up what we have.
Ms. Laura, the exam for this class, is it going to be just like question based, or is it going to have like an image review to it?
It's going to be in your pod. It's not going to be an image. No images. That's why I need you to understand the definitions of what the exploration of the radiographs is, just to put it in application form. So when you say radio densities, what does radio densities look like? Radio opaque objects, so on and so forth.
Okay. All right.
Yeah, we're doing the exploration on radiographs, so you kind of get an idea instead of just seeing words outlined in a text. But no
Gotcha.
images, not yet.
On my
When you get to the skeletal,
right
you will.
Okay. Yeah, that's the images. That's just the hardest thing for me.
Yeah, no. I really want you to understand what, like, let's say, if I say cystic fibrosis, is that an inherited or acquired condition? And you would say, well, that's inherited, so that's an easy, you know what I mean? And it's going to be multiple choice, true, false. You know my style. Nothing's going to change.
Yeah. Okay. Yeah, just looking at all the different images, like looking at like cystic fibrosis, that looks like so similar to to other ones. I'm just like,
it does, and this is why we're not getting into so much in the severity of like interpretation, but just an evaluation to see what an radiopaque density looks like, and so you can start putting applications to it. Okay, I think we're all on. Good morning, everyone. Good morning. Maybe I have one more.
Name is Sarah.
Hi. How are you?
Morning.
Good morning. Okay, so it is. Oh, I got one more minute. I'll be nice. One more minute before I make my announcement.
Miss Sarah, would you go over plus and minus pathology and artifacts, the density?
Okay, if we have some time at the end, I really just want you to know that radiopaque or plus density is something that is going to be very bright because it's taking more x-rays, or x-rays are not passing through it, so it's going through the absorption phase. Minus density is something like air. X-rays are just going to pass through it very easily, so it's going to have a darker appearance. But it's not going to look, if it's an artifact or it's a pathology, it's not going to look like the surrounding tissue. So if we look at something like, this, we know that if there was something right here, we would say that that's minus density, right? Because it has this coloration. If we're looking at something that is plus density, it would look something similar to this. This is why we're able to see these variations, especially in the lung, where you would take a normal lung and you would say, are y'all seeing what I'm...
Hey, no.
Oh, there she is.
No.
Good.
Hey.
Okay, we're all here. So
cinnamon.
You would see the differences and have the ability to identify what you're kind of looking at. Not pathology, because pathology is difficult. Because like Jonathan was just saying, there's just so much to look at that looks very similar. So I don't want you to pay attention. The images were just for putting in applications, what you see, a radiopaque, periphery, whatever. I want you to know your definitions. I want you to know your pathology. Got it? Okay, for example, if I said cystic fibrosis, is it inherited or is it acquired? You should automatically choose inherited because that's what you were given. Make sense? Yes? Perfect. All right. On Wednesday, I have a meeting. It's a leadership meeting for HR. So
No.
I will not be available from 9 all the way until about 12. So I am going to switch PRE. You still use the same link, okay? I'm not switching links. I still want you to select the 8 a.m., but I'm going to go over the x-ray tube. I don't want to lose my time for the x-ray tube. And I'm going to ask Mr. Donahue to use my 10:45 link time to do the pathology test for me. Got it?
No.
Because I'll say that again. On Wednesday morning, 8 to 9, you will still use the link that is provided. However, I will do PRE. I will go over the x-ray tube. And then my 10:45 class, instead of switching classes and trying to do all kinds of links, I'll ask him to proctor, him or Ms. Bourne to proctor my exam. Got it? So you still use the same time links. We're just going to switch the subjects because I will not be available after 9 o'clock. Make sense? Everyone understand what I just said? Okay? So no one is going to ask me, where is my PRE link for 8 a.m. on Wednesday morning? No one is going to ask me, right, Justly? No one. Okay, perfect.
Yes,
okay, thank you.
Switching the subjects. Got it.
Yeah, we're just switching, but using the same links. Perfect. Good. Love it. All right. So that just goes to tell you, you will not be taking my exam at 8 o'clock in the morning on Wednesday. You'll be starting the exam at 10:45. Good? Perfect. All right. So we left off at cystic fibrosis. We talked about it being inherited. Actually, we left off at emphysema. When we talked about emphysema, we talked about it being a reversible dilation, the elasticity of the alveolar sacs. And how many alveolar sacs do we have in each lung? Millions. Thank you, Marisela. Millions. And so we know that these are actually functioning units to inhale, expand oxygen, right? The capillary exchange is happening there. Push out, squeeze all that carbon dioxide out, right? So the alveolar sacs play a huge role in our exchange of oxygen and carbon dioxide. So once a person loses that elasticity, right? Kind of like the skin, right? Once you lose your elasticity, in order to fix it, you either got to take Botox or cut it off, right? Anyways, all right. No humor. Okay. All right. So it is the destruction of the elasticity of the alveolar sacs. Okay. So once they lose that, you start to lose that oxygen and carbon dioxide pressure. All right. Because we talked about having a sustained internal pressure inside of the thorax. Perfect. What appearance do they give? They give a barrel-chested appearance. Okay. And let me see. I was looking to see if I could see what that looks like. I don't know. Has anybody ever seen a barrel-chested? If we have time, I'll show you what that looks like because it's very interesting to see. All right. The next one is going to be any questions about emphysema? No? No questions? All right. So we are talking about lung neoplasms. A neoplasm is a new growth. A neoplasm is a new growth. A growth of what? If you have a new growth, you're not growing. We're not talking about bone growths. We're not talking about anything that you're still trying to grow into. Once you reach an adult, you're pretty much done growing. Make sense? So everything you were going to grow naturally is done. However, neoplasms are growths of something that is abnormal to tissue. And we reference that as tumors. New growths or neoplasms could be tumors. Tumors are tissue that is growing at a rapid rate. Tumors are growing at a rapid rate. Tumors are growing. See the notes on the side? Can't see the notes on the side. Which notes? Let me move this out the way. This one you're talking about? Let me move this back. Okay, sorry. I'll get to that in a minute. Can you see better? Yes? Okay, perfect. Okay, so tumors are tissue that's growing at a rapid rate. Okay, and they usually seem solid. They're not fluidy, they're not flowing, they're usually solid masses. So when you think about neoplasms or tumors, they're classified in two forms. They're either benign, which means it's non-cancerous. The treatment for a benign neoplasm is usually nothing. If it's not disrupting any type of systemic or body function, nothing. Okay? Sometimes you maybe just excising it, removing it. Okay? However, if it's malignant, it's different. It's going to need another course of action. So please know what benign and malignant is. Benign means non-cancerous. Malignant means cancerous. The therapy or treatment is going to be different. So in this one, we have a lung neoplasm, which is called a hamartoma. It is the most common benign pulmonary mass. What happens is you start to have peripheral. What does peripheral mean? Out, right? Peripheral, out, outer edges, outer borders. And this image is very difficult to see. That's why I chose the other one. It is mass. When you think of something that is mass, you're going to think of something that is solid, like a tumor, right? It's a mass. It's a mass of tissue that is rapidly growing. And it is going to look radiodense. What does that mean to me, Esbedi? Radiodense.
It's gonna look right in the image.
It's going to look white on the image, right? It's going to absorb those x-rays. Here, if you look at this radiograph, this is a radiodense object. It's lying right by the heart, peripherally. It is a radiodense object. It's very difficult to see. Can see that it's like, I'm not quite sure if that's what it is. Luckily, I'm not interpreting. But if I go back and I put this image, can you see the radiodense object in the right upper lung? Do you see the radiodense object in the right upper peripheral lung? Thumbs up. I see some heads. So now it's not the fact that you're going to tell me, oh, this is a lung neoplasm, Miss Lara. What you would say, or why I'm showing you these images, say, oh, Miss Lara, there's something that is right there, and it has a radio-opaque or radiodense image, or it looks like it. Make sense? So we know it is defined, it is sharp, it's got a defined shape. We know that that is likely a mass, okay? Because we wouldn't think the bronchioles would be that big out here. And so this is what pathology is. You're starting to identify not so much what is everything that we're learning, but what is radio-opaque or radiodense, and what would a minus density look like. Make sense? To kind of give you an idea of what type of pathology this person has. So everyone see this? And then we start to see another one right here. So good. Good. Any questions? No?
Yeah, I have a question.
Uh-huh.
At this point, the tumor we're seeing is a radio plus or minus?
Plus. Anything that comes in a whiter color, it's brighter, it's white. Then the surrounding tissue, it is radiodense. Got it? Because remember, Ruth, radiopaque means white. So all of this is a radiopaque anatomy, radiodense anatomy. It is absorbing more x-rays. This is a radio-opaque or radio-dense anatomy because it's absorbing more x-rays than its surrounding area. Make sense? Perfect. Good. All right. So lung neoplasms, pulmonary metastasis. Metastasis is something that does what? What does metastasis mean?
Spreads from one spot to another.
Please know that. It spreads from one part to another. Metastasis, when someone has a type of neoplasms that are metastasizing, meaning that they are moving location from one system or one location from the liver to the lungs. Now you have two separate systems that are being affected by the same type of neoplasms. Make sense? So metastasize or metastasis is that tumor, that growth is moving. How does it move? How will tumor, especially when it's malignant, move? It catches a ride. It catches a ride via circulatory system or the lymphatic system. It catches a ride from either the circulatory system or the lymphatic system. Mostly lymphatic system. Okay, because lymphatic system is our system that starts to remove toxins from our tissues. Okay, so it's a lymphatic system. So if a lung neoplasm and it becomes to continue wanting to grow, implant itself into other areas and continue to grow, it travels, it's called metastasis. So the lung neoplasm pulmonary metastasis is will basically say this is what you start to see. You start to see a lot of splotches, right? They start, and that it's not necessarily like we saw in the last one, very defined and sharp. Usually radiographic appearances, if they're very blurred, not sharp lines, it is usually determined preliminary that it's malignant. But if they have sharp circle, it's a sharp mass, it's got defined lines, it's usually determined as benign radiographically. Make sense? So the appearances of masses, whether they're blurry or very defined, allows the radiologist to interpret those images. Okay? So, but this right here in blue is basically telling you many cancers. Are you seeing, guys? Are you seeing this screen? The blue one, right? Okay, because my other one hasn't changed. So many cancers such as breast, colon, and prostate start elsewhere, and then they move and affect other systems. This is sometimes where you'll start to see cancers identified as stage 1, very local, localized. It's prostate cancer. When it starts to move into other systems, especially above the diaphragm, we start to get into stage 4s. Okay, they're more difficult to treat. Okay, all right. Any questions there? All right, so pleural effusion. We know what pleural effusion is. You studied it in chapter 2 with Mr. Donahue. Pleural effusion is when you have excess or free fluid in the pleural sac, right? Excess or free fluid in the pleural sac. What type of radiographic projections do we need, Sharon, in order to identify pleural effusion? If a patient cannot stand erect.
Decubitus.
Decubitus, perfect. If a person can stand erect, obviously we would want them to be erect. But if we need to see additional views of that fluid, free fluid, we will definitely place the patient on the affected side or on the unaffected side.
Unaffected.
For fluid, would we place them on the affected side? So if we see this in the left lung, here is the fluid. Would we put the affected side down for fluid, or would we put the unaffected side down?
Affected.
The affected side goes down for fluid, right? If you had free air, then the unaffected side, right, would go down. Perfect, because we want fluid to fall, air to rise. Fluid falls, air rises all the time, right? So if we're evaluating fluid, we want it to outline here. We want it to fall. If we wanted to evaluate air, we would put the affected side up so we can see it at the lateral border of the thorax. Perfect. Good. So pleural effusion is basically free fluid, right? Pneumonia is not. Everybody wants to say, well, pneumonia means air, because we heard of pneumothorax, and you want to say the pneu meaning that. Actually, pneumonia is more of an inflammation of the lungs. When the lungs become inflamed, tissue becomes inflamed. There is an accumulation of fluid. So we'll start to see fluid accumulate in between, right at different lobes. So we know how many lobes does the right lung have, Jaleisha?
3.
3. So we know that we can start to see pneumonia accumulate by those lobes, depending on what is being inflamed. So pneumonia can definitely be fatal to someone who cannot control it, because what is happening here, Luke, is do you think that there is an oxygen and carbon dioxide exchange happening right here? No. So this becomes potentially fatal if it's not treated, because what? A person can drown. They can lose the ability to exchange oxygen or breathe. Make sense? So this is where when people are having these issues, they have to seek some type of medical intervention, and whether sometimes they'll just put a tube in their chest to drain a lot of that mucus or excess fluid. Okay, so that's where you'll start to see those thoracic types of tubes being inserted. Any questions? Exciting stuff, right? Pulmonary edema. Edema means what? When you learned your words in chapter 1, what does edema mean? Anyone?
Swelling.
Swelling. It means swelling. So what is happening with pulmonary edema is that there is something that is happening with the heart. So a lot of people who are having congestive heart failure, they lack the ability to keep the fluids flowing. So if the blood does not get to the pulmonary circuit for oxygenated blood, it backs up. And that causes the swelling. And usually you'll start to see swelling around the heart. Okay? So pulmonary edema. And sometimes you'll see an enlarged heart. So what is pulmonary edema? Backup of fluid from the pulmonary circulation. Okay? Again, I'm not giving you radiographs. You will not have radiographs. You will have multiple choice for your definitions. Okay? Good. Respiratory distress syndrome, or RDS, is what? Somebody tell me what respiratory distress syndrome is. It's kind of in the name, but I want to hear you read it to me.
Someone that is breathing.
I'm sorry?
Someone that has is breathing, like the exchange of oxygen and carbon dioxide is really hard for them.
Okay, but why?
They just I think it's like one of the lungs. I can't remember exactly, Ms. Lara.
Okay, what does it say in your book it is?
Isn't it like most of the alveoli are congested and there's no gas exchange for like a lot of the alveoli?
Yeah, a lot of the alveolar. So you're starting to see a whole bunch. It almost looks like this image when you really look at it. You're thinking, wow, there's a lot going on from costophrenic all the way to apices, from the other apices all the way to costophrenic. And you're thinking, this is just something that is happening. on the whole entire image. But if you look at it, you don't really see the little white splotches that are evenly throughout the entire lungs. You don't see them on the tissue as much. Here, it's basically having, it almost looks like a pneumonia throughout both lungs. See, you see the white masses and the white masses and the white masses, or radiodensities. So respiratory distress syndrome is basically that. Someone is having very much difficulty, and there's going to be rapid intervention. Okay? And what does a syndrome mean by definition? Besides Johnnon, and his baby.
I think it's like a combination of hormones.
It is a combination of symptoms. I mean, a combination of symptoms. When you have a syndrome, if someone says, well, I have respiratory distress syndrome, it's going to be a combination of symptoms that are identifiable to say that I have this syndrome. So if someone is diagnosed with that, they have to be very careful, because as soon as those symptoms start to become or manifest themselves, they can become potentially facing death. Okay? So respiratory distress syndrome is just when someone is having a collection of symptoms that is making it very difficult for them to breathe, but it's not just incorporating one location, it's attacking the entire sets of both lungs, not just one. Tuberculosis, and if you notice, a lot of these highlighted red are quite important. So I would definitely look at to see which ones are red. Wink, wink. All right, so tuberculosis. It's contagious. What kind of precautions do you need, Naomi? What kind of precautions is tuberculosis? Standard precaution. What are we looking at?
We're looking at something that would spread through contact or anything else.
That's what I would think. But look right here. What does it say right there?
It is also airborne.
Definitely. So if you need an N95 mask for anyone besides COVID, you want to be looking for your tuberculosis cases. If a patient is coming in, and I know right now is a bit difficult because we were corona. I got it. But either way, if they're coming in and it wasn't corona pandemic going on and they had an N95 mask, that is your clue. Put on an N95 mask. We don't hand out N95s for no other reason to patients unless they are an airborne contact or isolation. Make sense? Your standard precautions when you see someone with an N95 mask, it is your cue to put on an N95 mask. So tuberculosis is probably one of the most dangerous types of bacterial infections. It is easily transmitted through airborne. So get your N95 masks and make sure. So if you see people putting that on, you don't need someone to tap you on the shoulder and say, hey, you need an N95 mask. Got it? Anytime you go into a clinical setting, you should be reading your surroundings. You should be assessing your surroundings. You should be following your TAC because you're still picking up that common type sense. Oh, I see an N95, I need to go on before I go into that room. Okay? Yes? Good. Perfect. Okay, the last of the last four, the occupational lung disease, I should say lung, sorry, not lug, lung. Occupational lung disease, and you'll see these on the commercials. Asbestos, silica, coal dust. Were you a coal miner and you have suffered that lung disease? Okay, these are occupational related type of diseases, and they've been lumped into this occupational lung disease. Okay, so what happens when you inhale these types of toxins? What happens is in the lung itself, fibrous tissue. What does fibrous mean? Now that you're in extremities, you should know what fibrous means.
Could you let Jessley back in? Could you accept? She accidentally got logged out.
Okay.
Thank you. But yeah, pertaining to this, it would be hurting the alveolar sacs, right?
It would.
Disrupting that exchange.
It would. But what does fibrous mean?
This is like kind of immovable connective tissue.
It's immovable. It's very sturdy. When you think of fibrous, you think of something that is very least in moving. Do we need to have movement in our respiratory exchange? So when you see fibrous tissue, you see how it's starting to form? It's almost like it's grabbing. Like this tissue is very much grabbing each other and you don't have that ability to move. So fibrous tissue formation is going to limit the movement, right? A person can have shortness of breath because they're not able to exchange or take in that full deep breath without experiencing some pain. So occupational lung disease, for people that are inhaling a lot of these types of dust and minerals, it'll settle and it'll start to create a scarred like tissue on the lung, which is identified as very fibrous. If you cut yourself and you create a scar, right? That scar does not look like your normal skin. Yes? No? Possibly? So that becomes very fibrous tissue. When you cut yourself and you don't get it sewn back appropriately, skin is going to develop or tissue is going to develop, but it's not going to develop in the epithelial way. It just becomes connective tissue. It becomes very fibrous. Its purpose then is just to connect two sides. Okay? And so that's what scars are. Scars are just connective tissue or fibrous tissue. Any questions? No? Sure there is. Chibo, I can barely see you. You there? All right. Okay, so moving on. We're moving on to abdomen. So when we think about abdomen, we're on chapter 3. One of the biggest ones that we'll see is going to be ascites. Ascites. Some people will say ascites, however, know how it's spelled. I spelled it correctly, I believe there. All right, so it is an abnormal accumulation of free fluid. Free fluid. What is the peritoneal cavity? Marisela, what is the peritoneal cavity? Do you remember? Help her out, Tracy. What is the peritoneal cavity?
Is it the cavity that holds in all the abdominal organs?
Yes, it does. And it depends. If it's intraperitoneal, those organs, some organs lie behind the peritoneum called retroperitoneal organs, such as the kidneys, right? The aorta, the inferior vena cava. And then you have the infraperitoneal organs, depending, but usually your bladder and the pelvic area. So the peritoneal cavity holds the intraperitoneal organs. Well, this is fluid that starts to accumulate inside of the peritoneal cavity. So literally, you will see patients who should look like this, but look very pregnant. Okay? That's not to say that everyone who looks like this is not pregnant. Your biggest identifier is going to be gender. Got it? Because you'll see some males walking around with a large abdomen of fluid. Okay, and it's very pronounced. So, ascites is the abnormal accumulation of fluid in the peritoneal cavity of the abdomen. Usually it's a sign of something worse. Okay? So it usually occurs with chronic cirrhosis, disease of the liver, or a metastatic disease, which means what again, Daniel? Metastatic or metastasis? What does metastatic or metastasis mean?
I'm not sure, Ms. Laura.
Okay. No. Huh?
Spreads.
Spreads.
I'm sorry. Put it one more time.
It
What does that
spreads.
exactly
It
mean?
travels.
It travels. Perfect. Thank you, Miss Aurora. It travels. So some type of cancer. Make sense? Perfect. Good. Here's that word, pneumoperitoneum. Pneumoperitoneum. That's not going for me. Pneumoperitoneum. Pneumoperitoneum. Opposite of pleural ascites. Opposite of ascites, we have pneumo, being air inside of the peritoneum. Pneumoperitoneum. So we will start to see free air accumulation inside of the abdomen. Remember, inside of the peritoneum, there is a balance, there is an exchange, okay? There is an internal pressure, even inside of the colon, right? So if you start to have an accumulation of free air, we know that that is pneumoperitoneum. If we were to look, and please remember, I will be bringing back in radiologic procedures. What position is best to identify pneumoperitoneum?
Left decubitus.
Why the left decubitus?
Because if we do it on the right, we can confuse it with air, like gas in the stomach.
So the left side must be down in order to move the air around the liver. The liver is a homogeneous mass, meaning it does not have any holes or cavities that air can get locked into. It's not hollow. It's very solid. So very, very good, Aurora. We would do the left lateral decubitus. Left lateral decubitus in order to identify pneumoperitoneum. Okay, perfect. All right. Any questions?
Yes, I have a question.
Sure.
I think I read on the book they say it's the presence of air and gas.
Gas is air. Yeah, gas or air is the same. Yeah. Good question. Anything else? All right. We're moving right along. We'll even have a little review time. All right, dynamic bowel obstruction. So what we're looking at here, and you're thinking dynamic, that means moving, free moving. Okay, that's true. Bowel obstruction. There are two types. There are mechanical and non-mechanical. There are two types, mechanical or non-mechanical. Whatever it is, a bowel obstruction is completely blocked. Now we're in the bowel. When I mean bowel, what does that say to me, Ascites? What does bowel? Where have I heard that word before?
Maybe abdominal movements.
Good. Bowels. If I wanted to describe a bowel, I would say the small bowel, the large bowel, right? The large intestines, the small intestines. Those are bowels. Okay. So if we think of a bowel obstruction and it is done in a mechanical way, and we're going to talk about the different types of mechanical bowel obstructions, it means that something is blocking. It's obstructing any peristalsis or any flow. Make sense? So a mechanical obstruction is something that can be done that is not necessarily inherent. So we're going to take a look at the differences. So complete or nearly blockage of flow, well, that is a bowel obstruction. So there are different types of mechanical bowel obstructions. Here's that word, fibrous adhesion. Here, if you really kind of look where these yellow arrows are pointing to, you'll see a narrowing. It's almost like it was the body had placed its own rubber band around that bowel. So a fibrous adhesion, remember fibrous is very strong tissue. It gives the inability of movement or stretching, elasticity. So it's almost like a constriction that was created on its own. the body just, whether it was trauma reasons, remember, because we develop scar tissue. And scar tissue is usually fibrous connective tissue. So either this person had some type of trauma, maybe the seatbelt in their car when they got into a car accident, put that pressure, that trauma on the abdomen, and this developed. Okay? So this is the most common type of bowel obstruction. Do you see it, John? You see the fibrous tissue right there? Perfect. Good. Crohn's disease. What happens with Crohn's disease, and you'll see this on the commercials as well, and if you haven't, now that you've been exposed to these types of words, you will. You'll be like, oh, that's what that means. Crohn's disease. Basically, someone who has Crohn's disease has an inflammation of the wall. If your wall lining is like this, person who has inflamed wall lining, the lumen or the diameter will get smaller. So if you take a look right here at the cecum, it's pretty inflamed. When the tissue on the inside of the bowel gets inflamed, it gets swollen, narrowing the lumen. Make sense? That's Crohn's disease. That's inflammation of the intestinal wall. Now, there's other types of mechanical bowel obstruction, intussusception. Yes.
Ms. Barr, I'm sorry. Just back to that last one. Look on the slide. It was talking about like the fistula.
A fistula is an artificial,
right?
Right. A fistula, it's almost like it's made. It becomes an opening, and people can make their own fistulas if something is not working. So let's just say this is not working very well, right? The body starts to evolve itself. It's trying to repair itself in any way that it can help itself. Fistulas become little like, I don't know, it's almost like they're growths. They become channels. They connect. It's almost like a bridge. So this rectum should not be connected to anything else other than the sigmoid. So they become like artificial openings to bridge into another part. So if we started to allow the small bowel to connect right to the rectum, then what would we be missing out on, right? If we dump from the small bowel to the rectum, we would never have the ability to do any reabsorption of any nutrients, right? Yeah? So you would think, okay, well, kind of fecal matter, more diarrhea, so on and so forth, right? Okay. So Crohn's disease. Fistulas are separate. I'm glad you caught that. The fistulas are like openings that the body makes and it bridges to other connections. It's also made of fibrous material. Even though it has a small lumen, it'll allow for some passage. But it's not. It's almost like an artificial, man-made bridge. It's not supposed to be there. That's what a fistula is. Okay?
Okay, so it's just made in response to the inflammation that's there. Okay, I got it.
Mm-hmm. Intussusception is basically called the telescoping. So what you're seeing right here, this smooth type bowel, and it's very dilated because small bowels don't get that dilated. So what basically happens is it's almost like a water hose being sucked into itself. So if you have a water hose, right? You have a water hose and it kind of folds into itself like telescoping. That's what that is. So what happens is that this bowel starts to telescope into the other section. What happens? This starts to get smaller as it starts to fit into the other portion of the small bowel. Well, what happens when this gets smaller? It narrows the opening. If it narrows the opening, could you have bowel obstruction? That's what intussusception is. Intussusception is telescoping of the bowel section. You have to physically remove it. This is more common in children, infants. A volvulus is a twisting. This can be done through any type of trauma. Okay? I've seen volvulus testicles. I know people are like, what, Ms. Laura, you went straight off into testicles. It's when you have a twisting of anything and it does not allow passage, that is considered a volvulus. And I say testicles because, you know, a lot of girls are raised in how do you protect yourselves from enemies, especially if they're the male kind. You kick them where? Okay, when you do that, it could possibly, that trauma could cause it to turn and twist on itself and become very painful. Okay, that can also happen inside of the intestines. Usually some type of trauma. Okay, good. Brain fried already on a Monday morning.
Ms.
All
Laura,
right.
sorry. In the previous slide, what is the big portion like of the or?
What they basically is just opened it. So this is the twisting of it, and this is just like it almost looks like a cecum. Because here's the small bowel, but this all see how smooth it is. It all looks like a small bowel. This looks like the cecum.
Okay.
And it also looks like it's swollen. So a lot of times when people have recurring Crohn's disease or re-inflammations, what they'll do is they'll cut off and reconnect. People who have cancers, colon cancer, if it's a cancerous area and they're afraid of metastasis, they'll excise it and reconnect the bowel to each other. Okay? So that's what that looks like. Here we have the small bowel because it's very smooth, right? On the large bowel, we would see hastra. We don't see hastra. Maybe right here. So this looks to me like the cecum. Okay. So these are the herniations, adhesions. This is that fistula that I was talking about. Eventually it'll start to make those artificial opening. Intussusception. Hernia is a type of bowel obstruction that's mechanical, and here is an idea of what it looks like on a volvulus. So just a diagram of what those look like. Okay. But remember, Crohn's disease is the inflammation of the inside of the wall. It would be an inflammation of the inside of the wall that it would have the ability to narrow the lumen. The lumen is the canal or the opening, the diameter of the width that something can pass through. A lumen. Okay? You with me? Sure. Okay. All right. An ileus. An ileus is a non-mechanical. An ileus is a non-mechanical bowel obstruction. It is usually caused from peritonitis. What does peritonitis mean? Javier, what do you think peritonitis means?
It's
Inflammation of the peritoneum. So it's inflammation of the peritoneum. So we know exactly what we're talking about when we talk about peritonitis. It's in the abdomen, right? It's in the abdomen. If we said pulmonary, then it would be in the lungs. If it says peritoneum, it's in the abdomen. So a lot of this or this type of non-mechanical bowel obstruction is usually after abdominal surgery. This is where you'll start to see a paralytic ileus. What is an ileus? Pamela, what is an ileus? It was from your anatomy of abdomen. I can barely hear you. But if you said the third section of the small bowel, you are correct. You have the duodenum, you have the jejunum, and then you have the ileum, right? So when the ileum becomes paralytic or paralyzed from surgery, anesthesia, whatnot, it stops working. And so you can have a bowel obstruction because it's not working. Peristalsis cannot move, cannot go through. Got it? And that is called an ileus bowel obstruction. Why? Because the ileum becomes paralyzed. Ulcerative colitis is also an inflammatory disease. We talked about Crohn's disease, but ulcerative colitis is specific. Ulcerative colitis is specific. It's specific to the rectosigmoid area. Crohn's disease is inflammation of the intestinal walls. Ulcerative colitis is inflammatory disease of the rectosigmoid area. Got it? This is also a condition that if a person has severe pain, and you have to think about it, these are ulcers that are lining the intestinal wall. So every time something passes through to expelling, it can be very painful. Make sense? So anyone that does suffer with this can have the treatment. If treatments don't help, like steroids, they'll also give steroids. But if that doesn't help, they would excise, cut out these sections and reconnect them. Okay? Or have a stoma. That's, you may see some people who have those artificial openings on the outside and they'll have a bag on their lower abdomen. Have you seen those? And that's usually a way to expel waste without having the use of the entire intestines. Okay? So don't touch those bags without gloves. I'm telling y'all now, put some gloves on. All right, and to the conclusion of our pathology, these were the sections that you were responsible for. These were the sections that you were responsible for. Didn't have to go through the quizzes unless you liked. Okay, there are some other words in there that we'll refer back to later. But for right now, I need you to know and make sure that you have these sections covered. Are there any questions of what we've gone over? It will be multiple choice. Please know your definitions. Please know your definitions. You don't have to evaluate radiographs yet. That will come in other chapters.
Ms. Lara, I do have a question. Those are very specific for Evolve Module 8, but for respiratory, with Ms. Bourne, we went over all 3 sections, and we also went over the quizzes. Do we just review?
I just want you to go back over. I'm not taking really things, honestly, out of Evolve so much unless it's something that, like your root words or your suffixes, your prefixes and your suffixes. So I stick to the PowerPoint on chapter 2 and then do the modules like I asked you to do on chapter 8 or module 8.
Okay, just wanted to
Okay.
make sure. Thank you.
Miss Laura,
The modules are very nice when you go back through them because they kind of lead you into identifying anatomy. But please know your anatomy. Please know your anatomy. Okay? I'm an anatomy person. So please know your anatomy. Yes, someone was saying something. I'm sorry.
yeah, I was just going to ask. The book, when I was reading about it, the book refers to like certain things that you can identify in these as lung markings. Are lung markings just like the infiltrates that you, or like the mucus that you see? Is that what lung markings are?
Lung markings, when you see something, let me go back to trying to go back to the PowerPoint. I can't get to it. Let me get trying to move my stuff out of here. Don't say. So here, when you think about lung markings, can you see this screen right here? Yeah? Y'all are seeing my screen? When you think of lung markings, you're looking at this. Anything that you're able to see that would be a normal. So if you looked at a normal chest x-ray, all of these little striations would be considered lung markings. A hilar region on a normal chest would look. But see how these are striations are here? Those are just lung markings. Those are bronchioles, right? We don't necessarily are going to see the alveoli because they're so small, but we're going to see bronchioles. what happens inside of the bronchioles, you're able to see them more evident. They're more evident when you have an accumulation of mucus. So when you start to see the pathology or accumulations of mucus into that, they become enlarged and you're able to see them more. That's a sign of distress or what an accumulation of something. So these are the lung markings where you're looking for anything that from the normal section to what would be identifiable as abnormal. So that's what lung markings mean.
Okay, so it's just so like the normal bronchial tubes or where you see in the hilar region, that's a lung marking. But then when you have like increased lung markings, that's when you have like the mucus that's built up.
You start to see distress and you start to see changes. So this is not normal. When you look at something like this, you're like, yeah, no, I've seen a lot of normal chest. Something's going on with this person, right? And you start to identify, because there's so many types of thoracic pathologies, you try to start making sense of what you see radiographically. But this does not look like normal lung markings, perhaps up here, but everything else starts to resemble something else, something that is abnormal. And pathology is the evaluation of looking for abnormal versus normal. So you compare it always back. Where do we start? We start at normal. What should normal look like so that when we come back and see something like that, you're like, ooh, something's going on right there. Make sense?
Yeah. So even like so with like a tumor, would that be considered an abnormal lung marking?
Yeah.
Okay.
That's an abnormal growth. If it doesn't look, if you shouldn't see masses, even if they're benign. If they're benign and they're in a safe place and the exchange of this system can still do what the function of this system can do, it's fine. But you should not see a mass. You know what I mean? That's a pathology. And the pathology has to be identified. And it's going to be identified, is it damaging? Is it risk to the patient, or is it non-risk to the patient? So even when you see something like this, it's pretty defined, isn't it? It looks very defined. And so when you're thinking that's a neoplasm, you're looking to see, is that a benign or is it malignant? And you start to look for those appearances. And that's what this class is showing you, that you can take these pathologies, even though right now I just want you to know the definitions. We can start looking at radiographs as you start to get more and more experience. You're going to see what abnormal looks like, because you're still going to be so used to normal. Well, we are Harris Health, so you're probably going to see a lot of abnormal, right? So anyways, anything else? Good questions.
Ms. Laura, for the tuberculosis, do you want us to focus on the primary and the reactivation?
Primary and secondary are just different. They're basically someone who's never had TB before. That's considered primary tuberculosis. So you don't have a history base, right? You don't have a history. But somebody who has had TB before and they have a flare-up, right? You're going to have a secondary. So how many of you, well, I won't ask you your private information, but you may go in and get a TB test and you're like, nah, it's going to show positive. Even though you don't have TB, you don't have active TB, but you have some type of enzyme that is indicating in your skin that you will have some type of exposure.
Thank you.
So that's reactive. For a person who has never had it, and that's why you have a TB testing every year. Every year I'm negative. But if I show up positive this year, then guess what? I've been exposed to it, right? And then they'll start testing me if I have active TB. Slap a mask on me. What kind of mask?
N95.
An N95. Good, because it's an airborne, right? See how much you guys are learning? Y'all are learning so much. I love it. Good. I can say words like that, N95. I don't have to hear you. I'm reading your lips. Good. I love it. Anything else, guys? Yes. And I'll see you at 10:45 for some good old PRE. Oh, I'm sorry, Sharon. Go ahead.
Oh, can I ask a question?
Sure.
When you said about radial dense, is this same like radiolucent? I'm confused of radial dense.
Radial dense. See how this right here is very. What color? What color do you think this is? Is it very similar to this?
Mhm.
Yeah. On a radiograph, when you have something that is going to absorb X-rays, it's going to give you a bright or white color. When something is radio opaque, or if the anatomy is radio dense, it means that this object, this mass, absorbed the X-rays more than the area around it. That's why I'm able to see this round mass. Okay? But if something was radiolucent, it does not absorb X-rays. It is the opposite of radiodense. It is going to allow X-rays to pass faster. Right? So the pathology that would be similar to opposite of radiopaque or radiodense, or would be considered radiolucent, would be what of chest that we've covered? What do you think would be most radiolucent type pathology? Come on. Anyone?
The lungs.
I'm going to tell you the easiest way to support
Pathology
TikTok without having to spend
would be radiolucent, would be emphysema. What is emphysema? You're like,
Loss of alveolar
we've
elasticity.
been talking about mucus and mucus and mucus. Wouldn't be mucus, right? It would be the absence of. It would just be that big old dilation. So right here, Sharon, do you see this circle? That is what type of color? Is that radiodense or radiolucent? Did it allow more X-rays to pass, or did it absorb X-rays?
Absorb X-ray.
If it absorbed, it would be white.
Mhm.
If it did not absorb and allowed it to pass, it would be black. So this right here is radiolucent.
Oh, okay.
Okay? It did not absorb. Okay? So those two things, practice that. But remember, emphysema, no mucus. It's just expanded. All right?
Thank you.
Okay, guys. I'll see y'all later. If there's any other questions, going once, going twice. Get some coffee. Get some energy. We got the tube coming up. Good stuff. Look at Luke. He's like, I'm on it. I'm on it, boss. All right. Bye, guys. I'll see you later.